So good afternoon. I think this is one of the interesting parts of this meeting that we have case presentations. I think this case is going to be presented by Dr. Deep Vora.
Good evening, sir.
Yeah, go ahead. Slides. So we have three examiners, Amit, I know, Prasad, I know. Okay, got them. Okay. Yeah, Dr. Sharmila is online.
So 57-year-old gentleman from Jalgaon, Maharashtra, presented with the chief complaint of chest pain, cough, and shortness of breath. So chest pain since 2 months, which is insidious in onset, gradually progressive, continuous and dull aching, mainly over the left side of chest, which is continuous and no relation to any movements or breathing. And cough is insidious and progressive, mainly dry cough, and dyspnea on exertion insidious in onset, gradually progressive, and now patient is not able to climb railway bridges without shortness of breath.
What do you mean by insidious in onset and gradually progressive? I'm confused. Are any of the examiners confused with that term?
Yes.
Yeah. Any of the other people here? You think it's right, it's wrong? I think it means the same, no? The two terms. So why are you including that? I find this very, very often in most of the exams. What about you, Amit? I think.
Yes, I think this conveys the same meaning.
Yeah. So I don't know, somehow from our grandfather's ages, it's come down and we copy it. So I think those things we should avoid. Yeah, go on.
And on inquiry, patient mentions the complaints low backache, which is also solely progressive but no radiation and no diurnal variation or any aggravated movements. No history of bleeding.
No, just go back to the previous slide. So I think if any of the examiners have to ask any on this particular thing. So are you satisfied with what has been told or the way it's been told? How do you expect it when you are examining a patient? I mean, one of the students. Or maybe I'll ask the students from this side. Do you think what he's told is right, or would you like to differ in that? Because I'm not sure who made the slides, or you put in a collective effort to make the slides.
So one by one, the chest pain for 2 months and cough, whether it is associated during cough also, whether it is associated with chest pain, need to be elicited. And
when you expect the chest pain in a lung cancer case, when you expect?
When the tumor is involving the pleuritic area, chest pain during cough can occur, or most commonly when the pleura is involved. And any history of weight loss or
when ribs are involved, bone is involved.
So further than generally, if it is in center, small, will not cause pain means the disease has
involved the chest wall.
T3, maybe if it is more than it's T4.
T3,
it's
T4
beyond T2. That bit it could be T3 or T4.
So I think what Dr. Amit is trying to tell you is any question that you ask, you must think about why you're asking that question. What is that you're going to infer from the answer that you get from your patient? Isn't it, Amit?
Yes.
Yeah. Yeah. Anything else? Okay. Go on then.
And there's no history of fever, loss of appetite or weight loss, and no history of orthopnea, PND, or palpitations or giddy.
So just go back. Now you tell me why you asked each one of these questions.
Hemoptysis part of just respiratory.
If he had hemoptysis or not, right? What does that signify to you?
Bronchus.
Yeah.
the tumor is involved.
Right.
The bronchus or not.
Right.
Fever to rule out the infection. Cox.
Okay.
Loss of appetite and loss of weight also for same, either for cox or malignancy, long.
Okay. So, like I said, whenever you ask a question, you must think about why you are asking that, because otherwise, just a routine run of questions is useless. Okay.
PND palpitation to road cardiac illness, cardiac component.
Okay.
And there are no similar complaints in the past. Nilcomorphism.
So let's just stop here. From your previous history that you've taken, would you like to just summarize it for us?
So 57-year male with nilcomorphism presented with a chest pain, cough, and shortness of breath, which is progressive. After 2 months of gestation, which is gradually progressive.
Okay. Anybody would like to ask?
What are the negative history you have told to us? Have you told about the? Go to the next slide. No history of.
Negative history is this.
No history of similar complaint in past. What that mean? I can't understand. Why you want to no history of similar complaint in past? What is the relevance of this?
Whether any prior cox or history, something which has some cough associated with some breathless or any effusions in the past, probably, if at all, extrapulmonary cox is one possibility where they can have chest pain or pneumonic effusions sometimes. Some recurrent infections are one possibility.
But generally, there must be consolidation. Mostly, it will have some other symptom also. Na? For a lobar consolidation, patient must have a fever and all that. Na? So I don't know whether this question is very much relevant. Similar complaint in past in this situation.
I also agree with sir. And also regarding the cardiac symptoms, all the other symptoms are not at all pointing to a cardiac cause. So I think that also may be avoided in this case.
Okay. So what did you learn from these comments now?
So when we ask the history, so based on the history, we have to find out what is the cause. So if we ask for any like chest pain, cough and all, so based on the history, what are the differential diagnosis we come to make, and to make it whether organ specific also we can, based on the history we can.
So all four of you are from Tata. Which year are you? All four. Okay, good. Yeah. Okay. So Tata's name is at stake now. Okay, go on.
So coming to the personal history, he's married and has 2 children and chronic tobacco chewer for past 20 years and stopped 2 months ago, and is never smoker and occasional alcohol intake.
No, just go back. Just go back.
Yes.
You've said he's a carpenter. What's the significance of this profession?
Just wood, dust, wood and dust.
Dust, wood. So
Possibility of
any of the examiners want to ask?
Yeah, I think you have carpenter means what sort of whether he is actively inhaling, can be the job profile can be active, and what are the other exposure you expect for a lung cancer idiopathogenesis apart from the smoking? Any other possible relation possible?
asbestos. Asbestos is
Along with
One
smoking,
it can be.
or in minus with radon, or with nickel, chromium, and those with the.
I think the other important factor, if this would have been female patient, then the household second hand smoke. That what I meant. That is more relevant in our scenario rather than these all this. And I think that has been established as one of the factor when we evaluate the how much second. So there is one parameter to check how much second hand smoke the person has consumed. There is a score to calculate. I am not able to recall. There are certain points. So that is more important in Indian context rather than this. If it would have been female patient, definitely this would have been an important.
So now when he's told you about secondary smoke, I'll ask you about tertiary smoke. What is that? Tertiary smoke. Haven't heard of it? Okay, homework. Yeah. Anything else you want to ask history-wise?
Why did you take the issue of marriage? He is married with 2 children. Any significance?
Fertility issue.
How relevant to this?
So just in case,
What's the importance of family history in lung cancer? How many times have you seen the lung cancer running in a family? And if yes, then what are the syndromes which are associated with the lung cancer? So you have to name 2 or 3 where the lung cancer, at least name one.
Amit, let him first answer the first question. Is lung cancer familial?
not so common. Not so.
Yes or no? Not so common.
Yes.
Yes or no? Other 3? Yes or no?
So T790M mutation, they are known to have a family.
Correct. 790M mutation people. Yes, it runs in the families. Yeah, so answer his next question.
Name the sum of the syndromes where the lung cancer can be a part which can be familiar, can be inherited. एक तो बोलो, एक तो बहुत कॉमन है.
Yeah, come. You have 2 more people to support you now.
Leaf-Romani syndrome, sir.
Yes, one. किसने इसने बोला था तो इसने बताया. But sir, meant to say, but we, if you are writing any family history, then you should be prepared for this question that if I am saying for family history, I should know that there are some rare syndromes which are associated with the, though it's not the first answer, no, it's not inherited. How many, even we have, I don't remember how do you, I think sir can tell very rarely in a 2 year or 3 year we can get that father, and even we are not very sure whether he had, the father had a lung cancer and now the second generation. So it's first answer we know it's not a inherited cancer. There are very rare genetic syndrome where it can be a part of it. That would be the right answer.
Yeah. So like I told you in the morning, you should not waste too much time on these steps. Otherwise you lose out on the time to showcase what you have learned in the 3 years for oncology. Okay? Yeah.
So coming to summary, 57-year-old male, chronic tobacco chewer, present with chest pain or left side dry cough and shortness of breath, occasional lower back pain.
Okay. So I think we've finished the history part there. Anything else you think they missed out on history?
You can conclude, sir.
Okay. All right. Yeah, go on. Who is going to present the examination? Same? Okay. Division of labor. Good. Yeah, introduce yourself.
My name is Dr. Deep.
Okay.
I'm from Tata Memorial Hospital,
Yeah.
second year resident.
Surgery?
Medical oncology.
Medical. Oh, everybody medical oncology. Very good. Okay.
On physical examination, the patient is conscious, cooperative, oriented to time, place, and person. His BMI is 20.3. Patient is afebrile at present. Pulse is 90 beats per minute, regular, good volume, and blood pressure is 126 by 88 millimeter of mercury in right arm sitting position. Respiratory rate is 22 per minute and SpO2 is 98% on room air. No pallor, icterus, clubbing, cyanosis or edema is seen. No lymphadenopathy. And the oral cavity examination, nicotine stains present over the teeth and gums, and dental caries are present.
Yeah, just stop there. Just stop there. Go back. Yeah.
What is the most important thing that is missing in this physical examination?
Did you hear him? Okay.
Performance status.
Performance status.
The second, which not very common, but very rarely it can present, you can see in the eyes. In a lung cancer patient, which syndrome you are associated with can manifest in the eye.
Dose of species. rule out two
Horner
doses.
syndrome.
What?
Yes. So what are the component of a harmless? So you can see what are the components?
Ptosis.
Ptosis, meiosis, and ophthalmosis.
So rarely if it is a upper, that is the superior sulcus
Superior
tumor,
sulcus
they can have a presentation with the pain radiating and can have a
There are 6 of you, so each one can name one component of that syndrome. 3 have been told.
Loss of cerebrospinal reflex.
Yes.
Anhydrosis.
Ptosis, meiosis,
Yes,
and
one more. One more.
anhidrosis.
One more.
Ptosis, meiosis, and ophthalmosis,
Yes.
anhidrosis, loss of cerebrospinal reflex.
One more. Okay, clue. Iris.
Aniridia.
Okay, homework again. Right. Anything else?
I think if you are including the spine, the vertebral column in the, then that, because that is the one of the sites. So if you are including into the systemic examination, then otherwise you can tell about the any spinal tenderness or not. If that is a part of a general physical examination, that should come into the, and lymphadenopathy, I think you have included that.
Okay.
If you have this, you can add it. If you have this, anything. If you have value to that.
So another clue is iris. I was telling you, look at the color. If it is a long-standing one, there is a discoloration. Heterochromia iridis. Okay. Right. Okay. Go on.
On systemic examination, on respiratory system examination, upper respiratory tract, nasal cavity and throat are normal. Lower respiratory tract examination, on inspection, both chest walls, chest sides are symmetrical. Trachea is in midline. Respiratory movements are decreased on the left side, and apex impulse is noticed in the left fifth intercostal space, just lateral to the midclavicular line. No localized swelling or depression or intercostal crowding is seen, and no dilated superficial veins or scars or sinuses or visible pulsation is seen. On palpation, the inspectory findings are confirmed. Trachea is central, apex bit is in the fifth intercostal space, lateral to the midclavicular line. Respiratory movements are reduced in the left side of the chest in comparison to the right side, and tactile vocal fremitus is increased over the left mammary and infraaxillary regions in comparison to the right side. On percussion, there is resonant node present on the both sides of the chest, except slight dull node present over the left mammary and infraaxillary side. Liver dullness is present. And on auscultation, normal vesicular breath sounds heard over the both sides of the chest, except in the left mammary and infraaxillary regions where bronchial breath sounds are heard. Vocal resonance is increased in that areas. There are no added sounds, no wheeze or crepitations. Other systemic examination, cardiovascular system examination, normal heart sounds are heard, S1, S2 are normal and no murmurs. Per abdominal examination, there is no palpable organomegaly, no liver or spleen palpable, no hernia, and per rectal examination, bilateral genital examinations are normal. CNS system examination, higher mental functions are okay, no focal neurological deficit, and spinal examination, there is tenderness present in the lower lumbar spine, but no focal neurological deficits. So basically, the patient is a 57-year male without any comorbidities, who is a chronic tobacco chewer, a non-smoker, presented with complaints of insidious onset, gradually progressive chest pain over the left side of the chest, with dry cough and shortness of breath, which is NYHA grade 1, associated with lower backache over last 1.5 months. On examination, he has suspected findings of consolidation versus mass in the left mammary and infraaxillary region, and with spinal tenderness present.
Did you examine the patient? You have examined.
Yes.
Okay. Anyway, we won't go into details about bronchial breath sounds. No, Amit? Okay. Yeah. Any questions?
What is your differential diagnosis at this point of time? The positive point and the negative point for both. Why you are suspecting and why you are differing with that. 1, 2, 3 in the order of most common or what are you suspecting?
So from the history as well as examination, it's respiratory system involvement with left side of the chest region, mostly lung parenchymal disease involvement. No, I mean, it's the findings are suggestive of consolidation or mass in the left side of the chest wall, but there is no history of fever or, I mean, no history suggestive of infections. So mostly, so goes in favor of left side lung pathology.
Probably of, I can say probably maybe it looks
Yes, sir. Probably a malignancy on this much history and examination, sir.
Because he's come to Tata. The 5 of you want to help him?
First TD I would keep is malignancy, sir. And
Why?
2 months history, no much fever, history of first history of
Examiners are there.
2 months history, which is slow onset, with no much fever history or weight loss history of infections. But still, second possible diagnosis would be COX with spinal involvement also. Port spine is also one more possibility.
what are the points which are in favor and what are then you can tell these are the, and I will like to confirm it by doing the further examination. So points in favor of malignancy, points in against the malignancy, points in favor of PBM, and that nobody can sure. So these are the points I'm suspecting, but these are the points which are not fitting into that. So that you can conclude. I think sir can also add to that.
Points in favor of malignancy, 2 months history, sir. And rest all the features are possibly in an infection also. May more 2 months history and patient is not
without
any treatment, patient is.
These may hints towards the malignancy, not the tuberculosis. That you can say. No one can catch you that why you are saying. These are your probability. Ultimately, we have to confirm with the investigation.
Okay. Yeah. Can we go on?
Yes, sir.
Okay.
So an investigation.
What would you do next? You can tell us that. Yeah.
So we would like to investigate this patient further. There will be the investigations for general condition, fitness of the patient as well as diagnosis of the patient. So for general fitness and further planning of treatment, we should do see complete blood count, look for hemoglobin. Patient is having shortness of breath on exertion, look for hemoglobin. Then we should do basic renal function test, liver function test, as well as coagulation profile, because we might end up going ahead with biopsy. But before that, we would like to do a chest X-ray. Look for the.
Do we have chest X-ray?
We don't have, sir.
Only CT scan. Okay.
When the patient comes, by the time 99% will have some or other form of imaging.
Right.
CT scan
Chest
was-
X-ray, I am not sure how much it will
CT
really have to
scan
our
was-
center.
CT was already done outside.
Yeah, most of them, yes. They come with a PET scan these days. Yeah. Do we have the films?
How severe was the
PET
pain?
films, yes.
How severe was the pain? And
Sorry.
how much was the
Requirement of analgesics and all that.
pain and tenderness? How
Spinal
much was the
tenderness. Patient is able to walk without any issues. Patient is having pain and there is tenderness while examination.
Okay, so this hemoglobin is normal. I think everything else is okay. Echo is fine. INR is okay.
So just among the blood investigations, which are the parameters is it important?
Still you, do you need to see some other labs value in this? Because we are not comfortable. We need to see some other things in the lab value. Are you comfortable with this value for a suspected lung cancer case?
Calcium
Yes.
and sodium.
Sodium. Sometimes you don't know it. maybe sometimes a small cell. So you need to see the SIDH and others. So the electrolytes needs to be the panel.
ALP with bone pain, ALP.
Okay.
So video actually.
So there's a video, is it? Okay.
It's not working.
Would you ask something about the imaging to them?
Directly,
Yeah.
you will go for a PET
PET
CT.
scan, yeah.
So the patient comes with a CT scan with the a lung lesion. There is no metastatic disease in the outside scan, and there is a metastatic disease in a outside scan. Then how will proceed differently in those cases?
The lesion is accessible, I'll go for biopsy, sir.
No.
No. He's
One-
talking about imaging now. He's giving you a situation.
There are two situations. One patient presenting with a CECT thorax with upper abdominal cuts, having a lung lesion with the bony metastasis seen in the dorsal vertebra. Second scenario, only the lesion is seen and there is no other lesion seen in the scan. So how you will approach those both situations different? Do you want to go ahead with PET CT in both scenario or not?
For second scenario, PET scan, I will go. Second scenario, sir.
Sir, in
Non-metastatic.
the patient having with the upper CT cut, we can see the adrenal glands. So if it, we can see that there is a deposit in the suprarenal region, then we can, most of the lung cancer shows meso to the adrenal glands. So in the upper CT scan, if the only the thorax has been done with the upper cut of the abdomen, then we can see the adrenal regarding the status of the adrenal glands.
So if on chest CT only with upper cuts of abdomen, we can decide that patient is having metastatic disease, not oligometastatic disease, metastatic disease, then we need not do a PET
That
scan.
I meant if the already and symptom is not coinciding with other organ involvement, CECT thorax with our upper abdominal cut is sufficient to, at least if it's showing a clear cut multiple liver metastasis, then there is no incremental value of doing PET in those cases.
In localized disease, if only chest is
Why?
involved,
What is the importance of PET in a localized?
so PET upstages the disease in up to 15% of patients from localized disease to
What is the
metastasis.
correct term used in oncology? With the help of the PET, how many what we call as a futile thoracotomies have been averted? What is that number? So there will be two situations. Some may be up stage, some may be down stage. So how it will help? So that is it's around 20%. The number is approximately so PET helps in preventing the futile thoracotomies by 20% in a patient with a localized disease presenting in an initial scan.
You want to do any extra imaging in this case, or you are okay with only CT or PET CT?
Brain.
Like to see the biopsy report first.
The biopsy is squamous cell carcinoma or adenocarcinoma. Will you do any extra imaging?
Patient is asymptomatic for any neurological symptoms. MRI brain is not compulsory. For a metastatic disease, it's not a baseline compulsory investigation to be done.
So as the stage increases, does the incidence of brain mets increase or decrease?
Increases.
How much is the increase? Any idea?
In stage 1, MRI brain can detect 3% of the cases. In stage 2, it can detect for 6% of the cases. And usually 60% of the brain mets are asymptomatic. So we do MRI brain also to detect brain mets.
Why is this concept changing from not doing an MRI a few years ago to doing an MRI now?
Sir, and if the patient is initial like stage 1 or 2, then the approach is different. We have to operate.
Sorry, asking that even in metastatic disease, now the concept is a little bit changing. That we need to, it's better to get an MRI, at least in some certain subset of the patients.
We are getting newer agents
Yeah,
which has
tell
good
me.
CNS penetration. So if at all if it's a targetable mutation, we are getting newer agents which are CNS penetrable, and so that we can
Right.
start and have
So
good.
till recently, even if we detected, we didn't have anything to offer them. But now that we are having so many things which can produce a benefit, it's better we know at baseline so that you can treat them also and follow them up. So that concept of not doing in asymptomatic brain mets is now slowly changed.
So patient is having back pain. What is the lesion that causes the back pain? Do you need any further investigations to address that issue?
MRI spine.
I mean, it depends on the clinical judgment. If you think that lesion needs to be addressed, we may need to do an MRI spine also.
On PET, there is a video. Sorry for the video, sir. Video is not getting uploaded. PET video is not. We'll go for biopsy.
That video is not running, is it? The PET scan video is not running? No. Okay.
Sorry, in investigation, there are two diagnostic and therapeutic. For diagnostic investigation, we need PET scan. We also need a biopsy. And for therapeutic implications, the patient is having adenocarcinoma, we also do for PDL1 EGFR cross mutation, and it has therapeutic implication.
Not do PDL1.
So we do.
EGFR.
L cross we also do squamous cell carcinoma.
But do how much patient of a squamous cell carcinoma will have a EGFR mutation and ALK mutation?
So in which specific population of squamous cell will you ask for these?
Predominance non-smoker. The smokers usually tend to have less incidence of driver mutation, sir.
Will you do NGS or EGFR for both? Why?
So NGS usually takes around 1.5 months to for the report. So
Take 1.5 months.
usually it takes time. RT-PCR is available very short span of time. We will do both, sir.
Facility available, technology available, NGS can get results the faster than the. So it's around. I mean, other centers it may be 10 days or 12 days.
Yeah.
So if facility is available, the current recommendation is to go for NGS. If facility available and patient is affording for the targeted therapy, then you don't need to the in our scenario where we know that resource constraint setting approach may be a little bit different. But in a affording population, you can get with the NGS with one panel, you can get all the information. I think before that, let's discuss the biopsy. I think, sir. So.
Okay. So I think these days you'll never do an FNAC, isn't it? It's all a true cut biopsy, right? Oh.
Left lung mass biopsy. It is adenocarcinoma. Tumor cells are arranged in acinar pattern with oncocytic morphology. On IHC, they are positive for TTF1 and negative for P40. So impression is it is adenocarcinoma.
So do you always need an IHC for diagnosis? Do you? I think I'm asking their question.
ISC is always required in a case of lung cancer. That's what sir is asking. Or you can get away without doing ISC.
Is what I mean is morphology now, or you would always want IHC?
Sir, if we sometimes morphological, if there are keratin pulse in, then we can also see this squamous cell.
Do you need ISC or not? That is the question.
Yes, sir.
Yes.
All cases?
So obviously people have not discussed with their pathologist ever.
So why we do ISC in a case of suspected lung mass lesion? What is the other reason for doing ISC?
To determine the origin of the tumor, if it is some mets from the other side or it is a primary pulmonary concept.
Whether it's a metastasis or primary site.
No, in this patient, let's talk about, you're talking about a hypothetical. In this patient, you know all the findings, everything. So here, do you still need an IHC? I think that's what you wanted, Amit. Yeah. Okay, I think homework with the pathologist. Right? Okay. Yeah, go on.
The EGFR mutation detection by RT-PCR is negative. Results of ALK immunohistochemistry is negative. Results of PDL1 immunohistochemistry is 1% tumor cells. So staining with weak intensity of PDL1. And ROS1 IHC, it is negative. So basically it's adenocarcinoma of lung with negative driver mutations with PDL1 of 1% with bone metastasis.
I wouldn't use that term negative driver mutation. I would say no mutations. Yeah.
Can you name some targetable mutations apart from EGFR, ALK, CROSS, HER2, BRAF,
Did not get your question.
MET,
MET, I did not get your question.
What are the targetable mutations in a lung cancer?
What are the targetable? Yeah, KRAS, MET, amplification, exon skipping mutation for MET, then NTRK mutation.
So in this case, do you are comfortable with the PDL1 report, the platform which is used?
It's by Ventana SP263. It's IHC assay for durvalumab that is
PDL1 is everything. So what is the specific platform used to define the eligibility of any immunotherapy?
2263 DACO.
Yes, so that is the DACO platform which is being.
So 263 is with which?
Then go to the discussion part.
How many percentage of EGFR exon 20 mutation can be missed by RT-PCR, which you can pick by NGS approximately?
So the gold medal wala sawal hai. In how you approach this case, I think there kind of discussion part. Sir,
Yeah.
do you want to add anything?
No, I think that's okay. Yeah, I think it's important that you know about these driver mutations thoroughly, because without that, you will not proceed any further. And that is the basis for all medical oncology today. And you need to be thorough with your molecular oncology. Otherwise,
The PDL, but there's a driver mutation negative. Otherwise, the whole Viva will go into the each. The ALK, what is the ISC? How much the concordance with the fish is ALK ISC sufficient to start the therapy or not? EGFR, what are the other rare mutations? What are the drugs which are acting on the rare mutations? Then the each efficacy of one TKI over the other TKI. Even one class should be on the one mutation. So this
Right.
data will be EGFR will take 1 hour for discussion. So since this is negative, we are not discussing, but that will come into the discussion whenever any lung case comes for all the newer therapies also, second line, third line, all that. So how will approach this case? EGFR, ALK, cross negative, PDL1, 1%. Patient is affording for everything.
Sorry. As the patient is symptomatic, we should start with the chemotherapy. It is Pemetrexed plus carboplatin plus temozolomab. This is based. If the patient is affording, then we should
Before starting chemotherapy symptoms, no, he has some other symptoms. We have to see whole of
bone met.
Yes, he has any bone mets. You have to consider for he is symptomatic for back pain and the cuff. So you have to consider for it to the bone also. No? You have to send them for the relative RD, and then you can come. Other thing before starting the fitness for cuff. So what are the basic investigation that needs to be done before starting immunotherapy in a standard setting? Our setting, what we do maybe something the list is a little bit longer, but in a standard setting, what are the baseline investigation? What baseline question you will ask to the patient before starting immunotherapy?
Any previous history of rheumatological disorders?
Yes, autoimmune disease. And what the other question? If the patient is an autoimmune disease, what other question you will ask? किसी को हो गया rheumatoid arthritis 10 साल पहले या 5 साल पहले?
On treatment for
Two steroids.
use of
that is the steroid. मान लो कोई 100 mg ले रहा है और कोई 10 mg ले रहा है, 5 mg ले रहा है. Is there any effect need cut off? और दूसरा सेकंड के any organ transplant or renal transplant, or at least in RCC and bladder we have seen few patients allogenic transplant and all that. So these questions should be asked. I think if it's less than 10 mg, if
10
I'm not
mg,
wrong.
yeah.
So if the
10 mg.
patient is on
So
a
long-term steroids, methotrexate, azathioprine, many of them do get. So those things you should ask.
the investigations, what you would like to do?
To go for thyroid profile, urine protein microscopy, 24-hour urine protein, lipid profile, ACTH, cortisol, and testosterone.
Generally thyroid profile and urine, what the literature says, but we do little bit more, but as such thyroid profile, baseline thyroid profile, urine is good enough as per the literature.
Okay. Now what will you start this patient? You already said, no, part of it. Okay. So he stopped you that you should send for radiation. Okay. Radiation done. What do you do next? Radiation done. What do you do next?
Then we will start after 1 week of the completion of the radiation. We will plan to start systemic therapy for this patient, because we will, as the patient is, we will start with the pemetrexed plus carboplatin plus pembrolizumab. If the patient is affording for the chemotherapy, if not,
Yeah. Amit already said, money is no issue.
when we give pemetrexed plus
So what
carboplatin,
discussion you will you do with the family?
yes sir.
You have to start. You are starting such a high end immunotherapy.
Yes, sir.
So the family will like to ask, इससे कितना फायदा मिलने वाला है? Why I will take? How long it should be continue?
Sir, based upon this keynote 189 study, so it have seen that in all subgroups of PD-L1 patients which have received chemotherapy plus
In this patient, though it has not been done by the exact platform, but PD-L1 which we have seen, the percentage is only 1%.
yes. So based, because there is a benefit in the OS on adding pembrolizumab to the chemotherapy backbone, and there is improvement in the OS and also in the PFS benefit. So
Each काम चलेगा. You have to come with numbers. You can't say there is a benefit. So everyone knows that there is a benefit. What is the magnitude of benefit?
Sir,
How was the response rate is better? What is the PFS benefit? OS benefit? I think
Sir, usually if we give only chemotherapy, the OS is around 8 to 9 months, sir. If we had pembrolizumab, if the percentage of PD-L1 is more than 50%, the OS is 30 months. If it is 1 to 50%, the OS is 20 months, sir. So we are adding around 10 to 11 months with the pembrolizumab, sir.
Okay. Patient's relative will say, I'll take 3 courses and then I will decide. Is that okay? Is there any minimum number of cycles you must take before you say? So that's a question I was trying to. So when do you assess response after you start
After
immunotherapy?
4 cycles, sir.
Yeah. So you can't say after 2 cycles we'll see if you're not responding, we will stop. So unlike what you do with chemotherapy. Yeah, Prasad.
No, before that, can you write the prescription for this regimen?
Yeah.
At least say.
Yeah.
so which you will start first. Where you place the DEXA? You have to write a prescription now. दूसरे को दे रहे हैं. So what he meant is which you will give you first.
Pembro. No need of any pre-medication for pembrolizumab, unless in the allergic reaction. Otherwise, not needed. Pembro followed by pre-medications followed by chemotherapy.
So pre-medication बोलो, no ही तो DEXA. क्या pre-medication दोगे? What are pre-medication in the?
So he's asking you to write a prescription. You're writing the orders for your patient. So what will you write?
Antiemetic and
What antiemetic? You'll write antiemetic? So
Granisetron.
tell him that, no, what drugs you're going to write.
Granisetron.
देखो क्या एग्जाम में जैसा सर मतलब फॉर सो if like in breast case what will be the new adjuvant and what new adjuvant
Yeah.
so ideally will be the I will plan for a FAC or FAC whatever with the best answer with I will plan the FEC with a 5FU with this dose, Adria with this dose, cyclophosphamide. So for 4 cycle, then I will reevaluate the patient. Patient will go for surgery. Then I will add the weekly paclitaxel at the dose of 80 mg per meter square. Then I will go. So examiner knows that you know all the, you have a clear cut picture in your mind how you will follow this patient with those. When you start saying, examiner will say, chalo theek hai. So that means he knows antiemetic, that is so granisetron. There's also, examiner will say, theek hai, we know that you know what are the, how to proceed. So whenever comes the question of tell it with the plan of the management whole. For asking disease, you have to tell, we reassess the PET CT, we'll go to do the IFRT, just not the ABVD. If you tell them the name of the drug with doses, and examiner will say he knows about the subject. So tell whole thing, not one.
So, pembrolizumab 200 mg, sir. Then followed by granisetron 1 mg IV, then followed by aprepitant can begin oral 125 mg on day 1 and day 2, day 3 80 mg. Then Evil can begin to 22.5 mg stack, and followed by Pemtrexate 500 mg per B12 injection prior to that. Then Pemtrexate 500 milligram per meter square, and followed by carboplatin AUC 5. Then post chemotherapy.
You don't give DEXA?
Steroids, avoid steroids.
ऐसा है क्या ओरिजिनल प्रोटोकॉल में ऐसा था डेक्सा दिया ही नहीं क्या पेमिट्रिक्सेट इनफैक्ट पेमिट्रिक्सेट का डेक्सा और भी देना पड़ता है
You have to give.
even for you have to give dexa for how many days after pemetrexate and why
4 days.
why you have to give dexa हर कीमो में तो नहीं देते ना अभी इम्यूनोथेरेपी के एरा में जो ट्रेडिशनल कीमोथेरेपी की इंपॉर्टेंस ही खत्म हो गई
Anything else you give with pemetrexate?
Folic acid.
How much?
Fine.
How often?
5 mg it
Daily,
is that
sir.
dose
Daily.
Daily.
dose क्या है folic acid का
Week 5.
सबसे और कम है because the tablet is not available for this therefore we are giving 5 mg 2.5 है 5 तो नहीं है that I'm sure it's not 5
Yeah. And we are not giving every day also. Now, once in 3 days is enough. Okay. Right.
You can give DEXA. Initially, there are concerns. That's why initial trials use snapbackly. But as a pre-medication, there's no harm in giving DEXA
Yeah.
along with this.
Yeah. That's right.
How many hours or minutes?
10 minutes.
Why?
That's what the drug insert says. Why?
Because there are transporters. So if we go for pemetrexate, the receptor is for insertion of penetrative. If we give slowly over 1 hour, the receptors get saturated. So it has to be given over 10 minutes. The receptor internalization, they get saturated if you give over longer duration.
Receptor.
What color is the drug?
Folate along with pemetrexate and B12 along with pemetrexate. Why not with methotrexate? When you give high dose methotrexate in lymphoma, you don't give beta B12. Why do you give beta B12 along with them?
Dihydrofolate reductase. So
it increases the efficacy of the drug by making those tertiary complexes and better activity of the drug. It's not for side effects.
One more homework, right?
And can you name some other drugs which have to given strictly within a time period?
Gemcitabine.
Any other drug?
Gemcitabine, how long?
20 to 30 minutes.
What happens if we give longer?
Increase bone marrow suppression. It will increase bone marrow suppression.
Increase. There's a paper from Tata Hospital itself from the last century of lowering the dose and increasing the duration. And gemcitabine was very expensive. It was a multicentric study led by Tata Hospital. We've shown that you could decrease the dose and the cost. Okay.
What are the toxicities you are expecting in this chemotherapy regime? The expected grade 3, grade 4, and the management.
Sir, in the 3 drug, when pembrolizumab with pemetrexed plus carboplatin, we can expect toxicities with the immunotherapy and with the chemotherapy. The chemotherapy, pemetrexed plus carboplatin, we rarely get grade 3, grade 4 toxicities, but they can be neutropenia, grade 3, grade 4 neutropenia with carboplatin associated with pemetrexed.
What percentage? What percentage? So you should know that, no, because of use of primary prophylaxis with growth factors. So you should know the percentage that you get grade 3, grade 4 febrile neutropenias.
20, 20.
50%.
20.
20.
I mean, do you use growth factors with PEM carbo?
No.
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 So it will be anyway below 20. No?
Then with the immunotherapy, most common reversible can be grade 3, grade 4 endocrinopathies, hypothyroidism, which is reversible and we continue on the same dose. And others, acute toxicities can be allergic reactions, anaphylaxis.
With the pembro,
Yes, sir.
which
We had
among
one
all
rash.
immunotherapies has allergic potential? There are various immunotherapy agents. Na? So which requires the initial pre-medication, the very newer one?
Trastuzumab with
Transfusion immunotherapy?
monoclonal antibody.
ऐसा मत बोलो. Avelumab, that requires the pre-medication with the Avil and all that. Oh, tell me the other common toxicities of immunotherapy. Na? Allergic reaction,
So
I don't think anybody has seen with the pembrolizumab any allergic reaction. And once you are saying that no pre-medication is required, you are saying there's allergic reaction.
The pembrolizumab can induce rash, then we can have this hypothyroidism, then we can have hypocortisolism, and
Common in most
Fatigue.
fatigue. चलो और जो ज़्यादा troublesome हो सकता है patient के लिए, and which we have. This is important that you have to tell the patient, भाई ये होगा, then you have to inform us. This symptom will come to you. You have to come to the hospital. You can't stay it at home. अपन जब लिखते हैं बोलते हैं ये होगा तो then you have to come. Patient will say हो गया ऐसे ही हो गया, बाहर खा लिया था हो गया इसलिए हो गया.
colitis.
You have to inform them that any new onset colitis, any new onset cough and dyspnea, these are the two most worrisome things when we are prescribing immunotherapy. You have to tell them in hand that if any news, you have to come and inform us, because the more we delay in starting the steroid for grade 3 and 4, the less chances of the recovery. So these has to be, and ideally the frequency percentage we should know what is the exact grade 3, 4. Then question will come the management of grade 1, grade 2, grade 3, grade 4. So how is the grading for roughly grading done for immunotherapy related toxicities? Take anyone for lung toxicity, or when we need to start the steroid in case of lung toxicity.
So grade 2 we require to start, grade 2 and above we require to start steroids. In grade 3, in grade 2 post steroids, when the patient there is reversal, we can start at the same dose, but in grade 3 we cannot start at the same dose. In grade 4 we cannot re-challenge.
Same dose. Is there any concept of dose reduction in immunotherapy?
No, sir.
Then why are you saying doses?
Grade 3 and 4 you cannot re-challenge. Grade 2 you can re-challenge. Grade 3.
Okay.
I think the immunotherapy toxicity part needs to, not for exam, for a day-to-day practice, because many indications are coming. So as a medical oncologist, we should be geared up to, because everyone knows the indication, but how to handle that is the biggest problem. So we should, as a medical oncologist, we should be well versed with the toxicity and handling the toxicity. That is more important than knowing the indication. Everyone will know the indication.
Absolutely. First, you need to know the toxicity and only then the rest of the things. Yeah, that's true. Okay, this patient has bone mets also. So what else would you do? You're given RT. What else will you do next?
Bone modifying agents, zoledronic acid or any
Zoledronic acid,
bisphosphonate.
bisphosphonate. Anybody else? Anything else? Why? Kidneys are fine.
And then zoledronic acid.
Not denosumab. I'll say I'll give denosumab. Anything against that? Or for that? Is there any head-to-head comparison of the two? No studies? Denosumab versus bisphosphonates. One more homework. Okay. Any other questions?
When will you assess the response? And how will you assess the response?
4 cycles, we go for a PET.
Want to assess clinically at each visit?
Clinically, every cycle, mid-cycle assessment followed by prior to next cycle also we call for mid-cycle for toxicities, then followed by prior to next cycle, just clinical assessment.
After 4 cycles, which imaging you want to do?
PET scan.
PET scan.
Initially,
Because patient had a PET scan earlier.
Is there any incremental value of PET?
CCT tab.
But if you do PET CCT component will be there in that. Na? So in follow-up, we do for some patients, those from the highest strata they want. Otherwise, CCT as such has a commercial, because all the response assessment is as per the RECIST criteria, which does not include the PET component. What are the type of responses you can see after the immunotherapy?
Progression or stable. After therapy, we can say either progression or stable disease or partial response or complete response. So,
eighth in chart term described है. हाँ तो that you are asking what are the और एक कौन सा term described है? That what we want. What are the type of results? So that should come up. These are the. It's not a conventional chemotherapy, na. They need to learn about the immunotherapy and the responses.
So you've asked them about iResist also.
Yes, I think there was a workshop going on the above radiology workshop.
so that is iResist is different from they we use usually for immunotherapy related responses. So for routinely when we use it's 30% or more it's progression, and for stable disease it's 30% to 20% will be this. But in case of immunotherapy related responses, the 50% or more from 50% to 25% will be the range for stable disease in case of immunotherapy related response assessment when we are doing. Majority of patients will be in stable disease criteria. After 50% only it will be progression or
presence of new nodules or met does not always label it as progression in case of immunotherapy. Why?
So the progression sometimes initially can happen with immunotherapies. So we need to repeat this scan at least 4 weeks later and see whether the progression is still there or not.
Okay. Is there a role of liquid biopsy in this patient? No driver mutations. Since I've answered all the questions, I'm going to ask you this question for your gold medal. No role? No. At a baseline and then as a part of monitoring therapy. What?
CD8 and CTL cells will be proliferated more.
Huh?
CD8 cells and the CTL cells.
Okay.
मैं गई नहीं
You're
ना
not giving immunotherapy.
मैंने कुछ पूछा ही नहीं ऑनलाइन भी अवेलेबल था तो मैं बोल मैं नहीं जाऊंगी फिर
We
ऑनलाइन
never asked Dr. Sharmila.
कल भी ऑनलाइन भी है।
Yeah, I think Dr. Sharmila, your chance to ask the last question. Sorry.
Hi sir, I
Hi.
would like to ask one
Sorry, we
question.
forgot
If there is a
completely.
progression, what is
Yeah.
the second line?
Okay.
If there is a progression, what will you be doing further? What is the second line which is available?
Yeah. Anybody? Second line.
Docetaxel plus ramucirumab or gemcitabine alone. So single agent gemcitabine.
Can you change the immunotherapy drug? No evidence. Yes. Dr. Sharmila, you heard the answer?
Yes sir. Yes sir.
You want to correct them? Okay, she agrees with you. I think we should close. Time-wise? Okay. Yeah. Final round of questions from the examiners.
Just a quick question regarding the EGFR. So, what will be the choice of therapy in a EGFR positive patient?
First line will be osimertinib. I mean, again, cost is not an issue. For
Yeah, here cost is not an issue.
How much benefit? So, when you are saying anything, then you should come up with the evidence. Na? Unfortunately, oncology runs on evidence.
Flora trial, sir, 18 months versus 10 months PFS. OS.
When you talk of osimertinib, we must talk of OS because that's the advantage with the drug.
What is the real benefit? Why it is more effective?
CNS penetration also there, sir.
Yes.
Yes.
So, if the patient is not affording for osimertinib, then what will be your choice?
Second choice can be, sir, gefitinib along with chemotherapy, prime carbo. The other choice can be allogeneic ramucirumab or
Osimertinib effective in all EGFR mutations or it is
T exon 20 insertion not effective.
any other mutation?
No, but he's asking that among the exon 19 and 21, is osimertinib effective in both or there is some differential response for those?
So exon 20 T790M mutation.
Both the T19 and 20 is excluded. That is a different thing. Upfront, when we are offering upfront osimertinib, do we see T7 and M0? So what is the first line indication? Which two mutation? Which
exon 19 21.
So this is effective in both or less effective in one or there is such no data?
Name some EGFR mutations. I mean, 1, 2.
S768I G. So three afatinib is actually preferred. L768I, G861X, and L719Q. Three mutations. Afatinib is better.
I think this is the last question. What are the newer molecules for exon 20?
So abimentamab and mobocertinib.
ये सबको याद होगा.
What is amivantamab?
Mobocertinib.
No, what is Yeah. What is it? Yeah, but what monoclonal antibody? There are so many monoclonal antibodies.
Yes, what? Amivantamab.
Okay. I think we finished 1 hour. So, any final comments by the examiners? What you want them to do better?
So I think first thing is that, but Sir has said that whenever you are giving the initial history, just think that local, like the organ is specific. So, and sometimes some examiners are, what will be the minimum T or N you can assess from the clinical examination and history. I think breast they commonly ask, and try to avoid the uncommon symptoms which might not. If examiner asks that, is there anything else, then because what sir said, that you have to quickly finish the initial part, because you want to go to your strength area rather than concentrating on the initial part. So if not much relevant past history, if anyone asks, then you can say, otherwise you can skip that. And third thing is, whenever you are giving any sign, symptom or negative history, you should have a thing in mind that why I have asked this question, so that someone asks, then you can have some. And regarding the genetic and all that, if you are saying no genetic, no family history, then you should be ready in your mind. At least in breast cancer cases, ovarian cancer, you should be thorough with the genetic part, that what are the various syndrome associated. That will come into the discussion at some point of time. The images which we are not able to show the images. Sometimes the examiner will show the basic anatomical structure of that particular organ. You should know where is the, at least in CT abdomen, but you should know where is the exact location of para-aortic lymph node, where are the common lymph node, roughly. No one wants exactly, but it should not that area is shown of a para-aortic and you are showing that there is a iliac node. So some basic CT scan you should be able to read. And in the last the discussion treatment part, whenever examiner asks that, tell me the management. So you have to start whole management plan, that what you are going to do. In lung cancer still is less, but for a breast cancer, like a HER2 positive breast cancer, so from NSCT you have to start and you have to conclude till the maintenance herceptin. So you start telling that this is my, and try to tell the exact regime doses if possible. Tell the dose and name of the drug, not tell the FEC. I will try to start with 5FU, so that examiner knows that he knows about when you will give radiation, when you will consider for surgery. So whole schema of things should come into the management part. Sir, anything you can?
Yeah,
add?
that's right, Amit.
You have conducted much more examination.
No. Yeah, that's true. Yeah. I think as you're taking history and waiting for the examiner to start, you put the whole thing as a nice picture in your mind, so that you should be able to anticipate what questions can be asked. You worked for 3 years in oncology, so you would have seen most of the cases. You would have looked at most of the situations. So just think it is just another day that you're seeing a patient in the OPD, but today you have only one patient. Okay. Yeah. So let me thank all my examiners and good participation, because you have a lot of homework now.